Okay. Then we'll move on to next topic is liver. Okay. So any idea about this anatomy of the liver?
It is located in the right upper quadrant.
Okay. Then
It has 8 segments.
okay, 8 segments. Okay. See, till whatever you're telling is clinical anatomy. This 8 segments is functional anatomy. This is a little different. Okay. Clinical anatomy has 2 lobes of liver, right and left lobe of liver. That's all. It has a falciparum ligament here and right lobe and left lobe. Sorry, this is right and this is left. Right and left lobe of liver. That is clinical anatomy. It has a bare area of liver above and below it has the gallbladder. This is clinical, but functional anatomy wise, what you told is correct. Functional anatomy. This is proposed by a French man known as Covinard. So we have to remember his name, Covinard. Covinard has given the functional anatomy of the liver. Okay, he has divided the liver into 8 segments with the help of 2 structures. That is HPV. Remember, hepatic vein and portal vein. Hepatic vein and portal vein. Because with the help of these 2 structures, he has divided the liver into 8 segments. Clear? Remember HPV because they will ask you. Functional anatomy of liver by Covinard is given by hepatic artery, hepatic vein, portal vein, hepatic vein, artery, portal vein. Like that, the combinations they'll give you. So remember HPV, human papillomavirus, HPV, hepatic and portal veins. Clear? Remember?
Yes, sir.
Yeah. So now this is the anatomy. So see here, what is this structure? This blue one, this one. What is this structure?
Inferior vena cava.
Inferior vena cava. Okay. So the liver is divided into, see, look here, look, we will just remember like this. Knuckles, okay, and the thumb should be inside. So if you carefully see here, 1, 2, 3, 4, 5, 6, 7, 8, and inside it is 9. Actually, it is 8 only because 4 has A and B, 4A, 4B. 1, 2, 3, 4, 3, 4, 4A, 4B, 5, 6, and 8. Inside is 8. Okay, so we have total 8 segments. 1 will go inside. 4 has 2 segments, 4A and 4B. Clear?
Okay, sir.
So see here, see the picture now. This is the left and this is the right. So see here, this is 2, 3, 4A, 4B, 1 goes inside. 5, 6, 7, and 8. Okay, 5, 6, 7, 8. The order is important. 5, 6, 7, 8. Here it starts with 2, 3, 4A, 4B, and 1 is inside. The thumb will go inside. Just if you remember it, it will be easy. The thumb is 1, then comes 2, 3, 4A, 4B, 5, 6, 7, 8. Okay, just remember this. So it has 3 sectors. Important is 3 sectors. Sectors are 3. Sorry. So the sectoral anatomy is important for resections of the tumor. It is important for resections. Why this is important? For resecting. If a tumor is there in one segment, so which segments to remove, that we'll see in the next. So this is 1, 2, 3, and 4. These are the 4 important sectors divided by 3 fissures. 4 sectors divided by 3 fissures. Okay. So this is the portal vein. Here, this is the portal vein, and these are the hepatic veins. Okay, this is the portal vein, and these are the hepatic veins. I'll just draw in another picture. See here, this is the, suppose this is the normal liver. So this is the splenic vein. This is the superior mesenteric vein, splenic vein and superior mesenteric vein. Both of them join to form the
Hepatic portal
Portal
vein.
vein.
portal vein. The portal vein will go like this, and it will divide it into left and right portal vein. And then there is IVC running behind the liver, and from this IVC we have the hepatic veins. Hepatic vein will be like 1, 2, and 3. So we have how many sectors? Sector number 1, sector number 2, sector number 3, and sector number 4. 1, 2, 3, 4. So 4 into 2, almost 8 segments we have. 4 sectors, 8 segments, based on divided by how many vessels?
2 vessels.
Which are the 2 vessels?
Hepatic vein and portal vein.
Portal vein. Okay. So this is a picture from lap cholecystectomy being done. This is the gallbladder being grasped, and below is a line. This line is Cantil's line. This line is known as Cantil's line. Okay. It is along the gallbladder and the IVC. I'll show it in another picture. This is not here. Okay. So out of this, we have 1, 2, 3, 4A, 4B, 5, 6, 7, and 8. These are the 8 segments of liver. Out of these, the named segments are: 1 is known as caudate lobe, and 4 is known as quadrate lobe. 1 is known as caudate lobe, and 4 is known as quadrate lobe. Okay, clear?
Yes, sir.
Yeah. Okay. So now remember one point. There is gallbladder here. There is gallbladder here. So if the gallbladder is having stones, what surgery will do? And if the gallbladder is having cancer, what surgery will do?
Full resection.
So we'll do cholecystectomy, right?
Cholecystectomy.
It has to be
Cholecystectomy
removed.
is done. In both the cases, it is cholecystectomy accepted. Cholecystectomy, in both the cases, it is cholecystectomy. Okay. But any change? For stones, we do what? And for cancer, we do what?
So for stones, we'll do a cholecystectomy.
Okay.
But if it is cancer, then we will remove the 4B and 5 lobes.
Yeah. So there is a simple chole. We call it as for gallbladder stones. We do a simple lap cholecystectomy. So we remove the gallbladder. It is enough. But for gallbladder cancer, we have to do what is known as radical cholecystectomy. The radical cholecystectomy. See the anatomy and tell me which lobes of the liver are to be removed.
5 and 4B.
Yeah, 5 and 4B. These are to be removed along with the gallbladder. Okay, so that lobes which are removed in radical cholecystectomy, the segments which are removed in radical cholecystectomy are 5 and 4B. Okay. Yes, no?
Yes, sir.
Yeah. So just remember that point. And
So you call them sections?
segments.
Only segments.
We call
Okay,
them
but
segments.
those are 8 segments.
8
But
segments.
with respect to the hepatic veins, sir, from the superior
Hepatic vein
part.
and portal vein.
Okay. No, sorry, I forgot the term. You divided them into 4 halves, right?
4
I mean,
sectors.
not halves. Sorry, 4 sectors. Yeah.
4 sectors. These are 4 sectors. 1, 2, 3, 4 sectors and 8 segments. Okay.
8 segments.
8
okay,
segments.
Yeah.
Okay. So now see another simple thing. Once you should recollect this every time, this image, so that it will be easy. So left hepatectomy. What is left hepatectomy?
So it would
Removal
be 2
of the
and
left-
3.
Left is
Left lobe will be 2, 3, and 4.
1,
2, 3, 4A, 4B.
4B. Yeah.
This is left hepatectomy. What is right hepatectomy?
It would be right one would be 5,
5, 6, 7, 8.
7, and 8. Yeah.
Okay. And then Left trisectionectomy is one up this side, left full and one sector above. Left trisection, 3 sections we are removing. Left trisectionectomy is 2, 3, 4A, 4B, and 5 and 8. Left trisectionectomy is 5 and 8. Now you have to tell me what is right trisectionectomy.
It would be
The right
5,
You have to
6,
remove the one.
5,
5, 6, 7, 8,
8,
Okay,
4A
and
and
4A,
4B.
4B.
4B. Very good. Okay, so remember these things. So just based on the single point of 1, 2, 3, 4 and 5, 6, 7, 8. Okay, just based on this, we have discussed about sectionectomies, hepatectomy and sectionectomy, trisectionectomies, and we have discussed about the radical cholecystectomy, what lobes to be removed. Okay, so this is the importance of this covinoid segments. Okay, so just once again, once you after this class also, you just recollect this image so that no need to mark it up. And exam also, just don't get confused. And so I have seen students, what they do is, see, one common mistake. So they start with good 2, 3, 4, 4A, 4B, and then they go from here. They'll start 5, 6, 7, 8. You should not do that. 5 here, 6, 7, 8. It is anti-clockwise. Sorry, it is clockwise. 5, 6, 7, 8. Okay, here it is clockwise. And here also it is 2, 3, 4A, 4B. 2, 3, 4A, 4B, like N. And it is clockwise. Remember like that. Okay? Yes, no?
Okay, sir.
Okay. And one important point regarding caudate lobe. What is this caudate lobe?
The
Caudate is
first.
the first lobe,
Yeah.
and the
See here,
quadrate is the fourth.
the first other lobes are all getting the blood supply through the hepatic veins. Okay, it's like they are draining through the hepatic veins. But lobe 1, it directly drains into inferior vena cava. Okay, so there is no hepatic vein here. It is directly draining through the inferior vena cava. So what happens? You have heard about an entity called Budd-Chiari syndrome in medicine.
Yes, sir.
Budd-Chiari syndrome. So what happens in Budd-Chiari syndrome?
There'll be obstruction, right?
Yeah, there will be obstruction to the hepatic veins. Okay, so what happens is all the other segments will become non-functional because of obstruction, except for
The first.
first segment. Yeah, very good.
Segment.
Except for the first segment, it becomes increase in size because it is the only functioning segment. So there will be caudate lobe hypertrophy. Caudate lobe hypertrophy in case of Budd-Chiari syndrome. This will be dealt in medicine also. Just you recollect this point. Why is we just, if you see medicine test also, you will see that why we have caudate lobe hypertrophy, because in Budd-Chiari syndrome what happens is it is a hepatic venous outflow obstruction. So all the veins, 3 hepatic veins are gone. Okay, they get thrombosed. So what happens? All the other segments, 7 segments, will be non-functional because there is no drainage at all. So the only functioning segment is segment number 1. So it becomes hypertrophied. Clear?
Yes, sir.
Yes, sir.
So this is the same thing. Okay. So important points we discussed is radical cholecystectomy. Radical cholecystectomy, what all we remove?
Gallbladder and 5 and 4B.
5 and 4B. Very good. So now so look here, this is the ultrasound picture. We have the, if you take an ultrasound, we have the common bile duct, we have the hepatic artery, we have the portal vein. What is it looking like, Jesse, here?
Portal triad.
Yeah, portal triad, but what is it looking like?
Mickey Mouse.
Mouse appearance.
This is the Mickey Mouse sign, classic Mickey Mouse sign. Okay, Mickey Mouse sign and ultrasound. It should appear like that only. The common bile duct is above, below it, beside it is the hepatic artery, and below it is the portal vein. We have this Mickey Mouse configuration. Okay, this is the liver pedicle. So coming to infections of the liver, is it clear? Anatomy is clear?
Yes, sir.
Yes, no?
Sir, what is the triad? Can you please explain? Like,
Yeah, this liver pedicle is there. So we have structures going into the liver. 3 structures will go into the liver: the hepatic artery, the portal vein, and the common bile duct. Actually, the common bile duct comes from the liver, but the three structures will be going into the liver. So when you see an ultrasound, you can see this configuration, Mickey Mouse configuration, they call it as. Okay.
Yes, sir.
Yeah. So coming to the infections, there are two common types. Yesterday we were discussing amoebic liver abscess. What type of pus is there?
Anchovy.
Anchovy pus. Okay,
Anchovy.
anchovy pus. And where you see red currant jelly stool?
Interception.
Interception. Very good. And can you tell me one sign of interception?
Target sign.
Yeah, claw sign. Claw sign. Target sign, claw sign, pseudo kidney sign. So many signs are there, but claw sign is important. You just recollect it. Okay, good. So move on to infections part. Infections, they are more common in cirrhotic livers. So alcoholic livers. Okay. So pyogenic liver abscess and amoebic liver abscess. Pyogenic liver abscess is through common microorganisms. Pyogenic. Amoebic liver abscess is through which organism?
Entamoeba histolytica.
Entamoeba histolytica. Yes. So in pyogenic liver abscess, what are the clinical features with which the patient present?
Fever.
Yeah, fever.
Uh,
Fever, pain.
Chills,
Fever with chills and pain will be there. Where will be the pain located? Pain will be in the
right upper
Right.
quadrant.
right upper quadrant. And history wise, the patient will be an alcoholic. Just in the history also, they'll give you a 50-year-old chronic alcoholic, cirrhotic liver, complaining of right upper abdominal pain and fever with chills. So it will be a pyogenic liver abscess.
So
Okay,
jaundice
and
would also be present?
Which one?
Jaundice would also be present?
Jaundice, in extreme cases, it will be present. Because see, for jaundice to happen, it is not the liver pathology, right? It should be the bile duct pathology. So if the if the abscess is so huge that it is compressing on the bile duct, then only the patient will present with jaundice.
Okay.
Yeah. So, and amoebic liver abscess is Entamoeba histolytica. So what will be the what is the investigation? Simple investigation to find it out.
Ultrasonography?
Just an ultrasound. Yes, very good. So an ultrasound just will be useful for us to identify the pathology. And what will you do it? This is important for us. What will you do? If there is an abscess, what you do?
We have
Aspiration and culture?
Aspiration and culture. Okay. So first of all, we can, if the abscess is small, like less than 5 centimeters, we can give antibiotics and we can wait. If the abscess is small. Okay.
We won't do a drainage at all. I mean, we will start with antibiotics first without knowing what sort of an infection it is. Would we do that?
In pyogenic liver abscess, we can just start IV antibiotics in pyogenic liver abscess.
Okay.
And we can wait how is the response after 48 hours. If the symptoms are decreasing, then no issues. We can just continue the antibiotics for 7 to 10 days and we can stop. If the symptoms are still persistent, then we have to go for aspiration, culture, and accordingly we have to see. Okay, for small abscesses only. For large abscesses, anyway, we have to go for drainage.
All right.
Clear?
Yeah.
Yeah. In the same way, for amoebic liver abscess also, what is the drug of choice for amoebic liver abscess? For pyogenic liver abscess, you can give the common antibiotic. For amoebic liver abscess, what should you give?
Amoebic would be metronidazole?
Metronidazole. Yeah, it is metronidazole, flagyl. Okay. So, what are the indications for IND in a case of amoebic liver abscess? This is important for us. See, large, if it is having large, like more than 5 centimeters abscess is there, you have to go for IND. More than 5 centimeters, large. Left lobe liver abscess. If it is left lobe liver abscess, we have to go for IND. If there is impending rupture, we have to go. In pregnancy, okay, we cannot wait, and in pregnancy, we have to go immediately for IND. And secondary infections, if there are other infections, apart from entamoeba, there are some other infections also, then we have to go for IND. So all these are self-explanatory. See, large we have to go definitely. Impending rupture, pregnancy, secondary infection. But why definitely? I am specifically telling left lobe of liver abscess. In left lobe, why we should go? So see, this is the kidney, this is the liver, this is the heart here. So any abscess in the left lobe, we have to drain, no matter what the size is. Why is it so? You're getting my point? Left lobe, drain only, IND only, no antibiotic, no IV. Why? Think and tell. Even if it's wrong, it's okay.
Because if we give IV means it's 100% biology.
Maybe rupture.
Yeah, it may rupture and it may go into the pericardium. Left lobe is very close to the pericardium. Okay, so we cannot take a chance. Okay, that is the reason why we go for any left lobe liver abscess. We go for IND. Okay, so see the indications. There is a small mnemonic for it. Large lips. That is the image here. Large lips. Okay, so just remember this. Large LIPS lips. So one is more than 5 centimeters. Second is left lobe of liver. I is impending rupture. P is pregnancy as is secondary infections. Okay, this you remember.
Could you repeat that again for me?
Yeah. Large lips, LIPS, lips. Large is L is 5 centimeters. Large is 5 centimeters. More than 5 centimeters, go for IND. One. Second L is left lobe of the liver. Why left lobe? It will go into the heart. If it ruptures, it will go into the pericardium. Left lobe. And I is impending rupture. If there is any impending rupture like this, if there is about to get ruptured, ultrasound, if you see it is about to getting ruptured, then you have to do an IND. And the patient is a pregnant, go for IND. No, we cannot give metronidazole in pregnant patient. And secondary infections, if there is along with amoebic liver abscess, if there are secondary infections, you have to go for IND. Okay.
Got it.
So see, then we'll discuss about hydatid cyst, hydatid disease, hydatid disease. It is caused by which organism? Microbiology.
Entamoeba.
Echinococcus.
Echinococcus granulosa, sir.
Sorry.
Echinococcus
Echinococcus
granulosa.
Okay. So see this cycle. The intermediate host is sheep, goat, and swine. Definitive host is dog. Man is an, what is man? Human is an accidental host. We call him as an accidental host. Okay, he's not there in the usual cycle. Accidental host. Okay. So microbiology classes are over.
Yeah, sir, they're done.
Yes, sir.
Okay, so this cycle you are well versed with it, right?
Yes, sir.
Okay.
So it means no human to human transmission, right?
No. See, it is man is an accidental host. That means suppose if he ingests the food material contaminated with the feces of these organisms, feces of these animals, then only we'll get infected. Okay. Direct man-to-man transmission will not be there.
Okay, sir.
So this forms a hydatid cyst. Echinococcus granulus forms the hydatid cyst. You can see in the picture. There is a multiple daughter cyst inside. Daughter cysts are there inside. There is, what is this? Inside one material is the hydatid sand, we call it as hydatid sand. And there are multiple scolices. Okay. So there is again a classification for you. So this classification based on the appearance of the cyst. There is a ultrasound classification for the hydatid cyst based on the appearance of the cyst. This classification is known as Garbi classification. Garbi. Okay, he's an Indian scientist only. Under his name, we have this Garbi type of classification. So there are type 1, type 2, type up to type 1 to 5. WHO is another one. But just remember this. What is the classification for hydatid cyst is Garbi. Okay. You can see here. There is a simple cyst, that is 1. You have a laminated membrane inside, that is 2. Multiple concentric, multiple scolices and multiple small hydatid cysts is 3, and irregular is 4, and it is almost calcified, it is 5. Okay, this is the Garbi classification of hydatid cyst. So here, what is the drug of choice for hydatid?
Albendazole.
Albendazole. So here, see
So
the
what are
technique.
the indicatments? What are the clinical features like here?
Yes, same. Like Hydatid says, this right abdominal, upper abdominal pain. If the chest gets infected, they will have fever. The same features. Mostly they will be incidental finding. Once you do an ultrasound, you can find a cyst most of the time. And the symptoms also can be the right abdominal pain may be there. Or the patient can come with fever if there are secondary infections.
Okay, so basically most of the time is asymptomatic or just it comes along with pain?
Yeah, most of the times it is asymptomatic.
Okay.
We'll have large Hydatid, unless it is very large, the patient will not have any pain and all.
All right.
So the treatment wise, the drug of choice is albendazole. Here, see what we are doing is, this is known as pair technique. Puncture, aspirate, inject. So this technique is known as pair technique. Pair technique. Puncture, you just puncture, you aspirate. Whatever material is there, you aspirate. You inject. What you inject?
Albendazole with 20%.
No. We cannot inject albendazole. Albendazole is given orally. We will give.
Scolicidal agents?
We'll give some scolicidal agent. That is, which will kill the scoliosis. Scolicidal agent. That is 20% NS. Hypertonic NS. Normal NS is how much? It is normal NS
9%.
concentration.
0.9.
0.9%.
0.9%. So here you are giving so much, 20% hypertonic saline, or you can give betadine. Okay. We'll give this inside. We'll inject it, aspirate and inject, and again you have to re-aspirate it. This is known as pair technique. Puncture, aspirate, inject, and re-aspirate. So what are the contraindications for pair? In which patient you cannot do this pair? See, if it is a dead cyst or a calcified cyst, your needle only won't go inside. You can't do it. If there is a deep-seated or extrahepatic cyst, your needle will not go again. Multiloculated cyst, if there are multiple locules, as in type 3, if there are multiple locules, you will just aspirate one and the others will be like that only. So you cannot go in multiple loculated cyst. And if there is cystobiliary communication, that is, there is a gallbladder and bile duct here. If there is a cyst here, there is a cystobiliary communication. So if you puncture and aspirate, what will happen?
The contents would be spilled inside the bowel duct?
Yeah, it will be, you are giving the contents, you are giving the injection into the cyst, into the biliary tract, which will be very dangerous. Okay, this hypertonic saline can't be given into the biliary tract. So this is a contraindication for pair. So one is dead cyst, calcified cyst, deep-seated, which is not amenable cyst, extrahepatic cyst, multiloculated cyst, multiple locules are there, or if there is cystobiliary communication, you cannot use this pair technique. And is it clear? Infections, pyogenic, amoebic, hydatid cyst. Yes?
It's clear, sir.
Could you show the last slide again, please? What's the difference between a dead cyst and a calcified cyst here?
Calcified means it is having fully calcium deposits, it is a calcified cyst. That dead cyst is long, if there is no calcification also, we call it as a dead cyst if there is no activity in it.
Okay.
If there is no broods, what do we call, the scoliosis are not there, okay? If there is no activity inside, it is known as dead cyst. Almost they are same. Mostly we will not find the dead cyst alone. We will have this calcified cyst only. Okay, we'll move on to the next thing.